Liver disease, hospice eligibility, Medicare LCD. Liver disease, hospice eligibility, Medicare LCD criteria and case study, parish health systems. Eligibility training. LCD criteria overview. Patient must meet both.
End-stage liver disease is supported by laboratory evidence showing significant hepatic dysfunction, including a prothrombin time more than 5 seconds over control or an INR greater than 1.5, along with a serum albumin level below 2.5 grams per deciliter. These abnormalities reflect impaired synthetic function of the liver and help establish the severity of disease in the context of hospice eligibility. Eligibility is further supported when the patient has experienced one or more major complications of advanced liver failure, such as refractory ascites that no longer responds to medical management, spontaneous bacterial peritonitis, SBP, hepatorenal syndrome indicating severe renal involvement, refractory hepatic encephalopathy despite treatment, or recurrent variceal bleeding. These complications demonstrate progressive decompensation and significantly contribute to a limited prognosis. Supporting documentation for end-stage liver disease may include evidence of progressive malnutrition and muscle wasting, ongoing heavy alcohol use exceeding 80 grams of ethanol per day, the presence of hepatocellular carcinoma, or chronic viral hepatitis such as hepatitis B surface antigen positivity or hepatitis C that has not responded to interferon therapy. While not required for eligibility, these findings further demonstrate advanced, irreversible liver dysfunction and help strengthen the overall clinical picture. Key documentation should clearly include the patient's INR, prothrombin time with control value, and albumin level, along with details that demonstrate the severity and progression of liver disease. It is important to note the frequency of paracentesis when managing refractory ascites and to document specific dates of major complications such as spontaneous bacterial peritonitis, variceal bleeding episodes, or episodes of hepatic encephalopathy. Adding objective severity measures like Child-Pugh and MELD scores strengthens the clinical picture, and transplant status, whether listed, declined, or not a candidate, should also be included when relevant to support prognosis. This 62-year-old female with long-standing alcoholic cirrhosis has experienced a progressive decline after more than 30 years of heavy alcohol use, despite having stopped drinking 6 months ago. Her course has been marked by multiple complications consistent with end-stage liver disease, and she is not considered a transplant candidate due to her recent alcohol use and a history of non-compliance, further limiting treatment options and contributing to a poor overall prognosis. The patient's laboratory profile reflects severe hepatic decompensation, with an INR of 2.4 and a prothrombin time 8 seconds above control indicating markedly impaired clotting function, and an albumin level of 2.1 grams per deciliter demonstrating poor synthetic capacity. Her bilirubin is significantly elevated at 8.6 mg per deciliter, and an ammonia level of 98 mcg per deciliter supports ongoing hepatic encephalopathy risk. Overall disease severity is further captured by a Child-Pugh Class C designation and a MELD score of 28, both consistent with advanced end-stage liver disease and a high short-term mortality risk. Major complications, past 12 months. The patient has experienced recurrent, severe complications of end-stage liver disease, including 3 hospitalizations for spontaneous bacterial peritonitis, an 8-day stay in March 2025, a 6-day stay in June 2025, and a 7-day stay in September 2025. They also required intervention for recurrent variceal bleeding, with EGD banding and transfusion of 2 units of PRBCs in May 2025, followed by rebanding and 3 units of PRBCs in November 2025. Hepatic encephalopathy remains poorly controlled, with 2 to 3 symptomatic episodes per week despite optimized therapy with lactulose and rifaximin, demonstrating progressive and refractory decompensation. The patient's current clinical picture reflects profound end-stage liver disease, marked by massive refractory ascites requiring paracentesis every 2 weeks with removal of 5 to 8 liters each time despite maximal diuretic therapy with spironolactone 200 mg and furosemide 160 mg. They exhibit severe jaundice and recurrent episodes of hepatic encephalopathy, accompanied by pronounced muscle wasting and a 17% unintentional weight loss from 142 to 118 pounds. Overall, the patient demonstrates profound weakness and fatigue, consistent with advanced decompensation and poor functional reserve. Common documentation errors include failing to record both INR, PT, and albumin levels, omitting dates of key complications, and not specifying the frequency of paracentesis, which is essential to demonstrate refractory ascites. Clinicians also often leave out diuretic doses needed to show maximal therapy, neglect to include Child-Pugh or MELD scoring, and fail to document transplant status, all of which are critical elements for accurately establishing end-stage liver disease severity and hospice eligibility.